I think 49 is a pretty good starting number. Okay. So my name is Stephen Caruana. I'm a member of the Australia OPCAT Network, and we've put this sort of presentation forward in response to the issues that we're seeing domestically and globally around prisons or places of detention, human rights, and responding to the COVID-19 pandemic. So before we start the presentation, just a reminder to everyone, please keep your microphones on mute for the duration of the presentation. And when it comes to question time, you're more than welcome to use the chat box to let me know you have a question, and then I'll pass it on to you. For those joining by telephone, I'll give opportunity at the end for you to also ask questions. Before I introduce our very special guests, I'd like to first of all acknowledge the traditional people of the lands on which many of us meet today, noting that we have representation across Australia, New Zealand, possibly Canada and elsewhere. And I think that's pretty important, noting that Aboriginal people are some of the most highly incarcerated people in the world. And I'd also like to acknowledge people with disability who are also disproportionately represented in carceral environments. I'd like to kick off so we can get the most out of this. We have quite a lot of people joining us from varying aspects, from NGOs, from academia, health professionals, monitors from across Australia and elsewhere, representatives from the UN, and just a plethora of different people. And I think we can, though we may approach this from very differing positions, I think we can all agree that human rights underpins all of our work at this present time. So I thought this was quite an important presentation to hold. So without further ado, I'd like to introduce Dr. Jens Modvig, who's the chair of the United Nations Committee Against Torture. He's also a medical doctor and does a lot of work for the organization Dignity, which is the Danish Institute Against Torture. He has experience as a monitor, as well as within the medical field, so he provides a very rich degree of experience and knowledge on this topic. So I'd like to pass over to Dr. Modvig.
Thank you very much, Stephen. Can you hear me?
Yes.
Good. Actually, I'd like to start with a disclaimer. And that disclaimer is that this is a new field. It's a new field to all of us. It's not like general monitoring, where we may have years of experience and can speak freely about all aspects. We're actually in a virgin field here, and this means that maybe some of my points may seem a bit either basic or even preliminary, and are only some first considerations. But I do hope that there will be some contributions to the general understanding of what we're supposed to do as NPMs and human rights defenders. The corona pandemic, in fact, puts two very different challenges on bodies doing preventive monitoring of places of detention. The first one is we now have a completely new area to monitor. That is the way the authorities manage the epidemic in places of detention. And we have a new place of detention, namely quarantine locations. They may have been there before, but now they have come up as a highly relevant area for consideration. The second challenge is a methodological one. That is, how can we continue monitoring while respecting the restrictions in, for instance, human interaction that emerges completely naturally from efforts to limit the spread of the epidemic. So these two issues, the new area for monitoring and the methodological challenges, will probably be the through-going themes in what I expect to talk about. Starting with monitoring the authorities' management of the epidemic, the first point here, as always, is to monitor whether procedures and conditions are in compliance with human rights and offer sufficient protection against torture and ill treatment. Just like with the war against terrorism, there are specific concerns in the efforts to prevent transmission of COVID-19, which may urge the authorities to implement measures which do not sufficiently take respect for human rights into consideration. On the other hand, the management of the epidemic may also compel the authorities to take steps to reduce transmission, which requires lowering security standards, for instance, releasing criminals from the prisons. Considering prisons in an epidemic context, they should be considered potential incubators of infectious diseases. Like other public residential institutions, social care homes, the inhabitants live close to each other and sometimes have physical and psychological disabilities, which may further increase the risk of spread of infectious diseases. This is a generally accepted fact, although personally I've had some difficulty in finding convincing scientific evidence for it. When the authorities deprive a person of his or her liberty, they also take on the responsibility for their health. This follows from the limitations of freedom of movement, but also from the fact that in most prisons, the inmates are obliged to use the in-house prison health service and have only very limited possibilities of using the general healthcare system. In this respect, acquiring a serious disease during imprisonment due to lack of due diligence or receiving insufficient treatment for a condition may amount to ill treatment or even torture. Considering this increased transmission rate in prisons, it's important to assess whether the management of the epidemic effectively minimizes the transmission of COVID-19 and, in case of infections, provides adequate treatment. SPT, the Subcommittee for the Prevention of Torture, in its 25 March advice, advises that states should identify and focus on vulnerable groups. They should reduce prison populations. They should reduce overcrowding to allow social distancing. They should review cases of pretrial detention, review the use of immigration detention, screen at release, minimize restrictions on regimes, ensure complaint mechanisms are functional, respect daily outdoor exercise, allow equivalent hygiene, ensure alternative methods of contact with the outside world, enable food provision by relatives, ensure medical isolation is not disciplinary, provide medical care outside the detention facility, ensure information about measures taken, protect staff, provide psychological support to staff, and ensure that all points apply also to involuntarily admitted psychiatric patients. Many other instances have also issued guidelines to states, and Dignity has published a 10-point synthesis of the available guidances. In short, these 10 points are as follows. Recall the equivalence of care, I'll get back to that. Develop COVID-19 management plans coordinated with public health authorities, I'll of course also get back to that. 3, only limit detainees' freedoms as necessary and not punitive. 4, prevent virus entering, spreading inside, and spreading out from prisons. Consider alternatives to visitations. Ensure minimum 1 hour in open air. 7, ensure accommodation and healthcare for released individuals. 8, give intergovernmental organizations access to fill service gaps, if any. 9, adopt alternative measures to maintain functioning of the criminal justice system. And 10, NPMs should find alternatives to physical visits and monitor quarantine locations. So as you can see, there's not much difference between the different guidances that have been published, SPT guidances and many others. And when we synthesize, we get these 10 points. SPT also made recommendations on to NPMs on how to tackle the pandemic. And NPMs should continue exercising their visiting mandate, taking into account legitimate restrictions imposed on social contact. It's incumbent on NPMs to devise methods of fulfilling their preventive mandate which minimize the need for social contact. And ideas that was floated by the SPT is discussing with authorities implementing standards, increased collection and scrutiny of data on places of detention, electronic communication with inmates and staff, NPM hotlines, track setting up of new places of detention, and enhancing collaboration with NGOs working with inmates. In summary, the human rights situation of people deprived of their liberty is under pressure from two sides: measures to prevent spread of the disease, quarantine, no family visits, which impedes on human rights, and a substantial limitation of oversight bodies, including NPMs, to exercise their preventive monitoring. In this context, SPT's encouragement to NPMs to think in new ways is very welcomed and necessary. It would be very interesting to take stock of this situation globally at some point, when new and promising methods actually developed. How then can NPMs monitor how the authorities manage the epidemic? First and foremost, this depends on the context and the way the system is organized. In centrally controlled prison systems, the NPM could engage with central authorities and request the relevant information, such as in the prison system, which I will concentrate on, the prevention and management plans, which measures the authorities have taken to reduce the prison population, which procedures apply for screening and testing on admittance and release, which measures are taken to protect vulnerable groups, which facilities and procedures apply for quarantine, which are the procedures for family visits, which are the procedures to protect staff, and what are the data on the development of the epidemic. I will go through these point by point and elaborate on how NPMs could actually evaluate the information provided. If the information is provided in sufficient detail, the NPM would be able to evaluate the actions taken by the authorities and make recommendations as appropriate. Starting with the overall prevention and management plans. While some authorities, for instance the Danish, are hesitant to make their prevention and management plans public, NPMs should be able to, possibly confidentially, to evaluate plans for management and prevention. While many of the measures to be considered will be dealt with in detail below, an important overall feature of the management and prevention plans are which scenarios are considered. Do the plans take into consideration scenarios where a major part of the staff and the prisoners catch COVID-19? Are the lockdown measures foreseen acceptable and in compliance with prisoners' rights? Are measures likely to create substantial dissatisfaction among the inmates? Is there risk of riots or violent attacks against staff? Are there a pool of temporary staff ready to step in case of substantial sickness absence among the usual staff? The overall evaluation of these questions may give rise to recommendations to the authorities. Next question would be whether the authorities have effectively reduced the prison population. Those measures could include, for instance, reducing intake by postponing serving sentences for as many as possible. That has actually been done in Denmark. And scrutinize the use of pretrial detention to make sure that all cases fulfill the legal requirements to the letter. Increased release could include early release of prisoners approaching the end of their sentence and releasing vulnerable prisoners when possible. I'll get back to that. As an example, the Chilean government yesterday decided to release 1,300 prisoners to serve the rest of their sentence in house arrest instead. These were people sentenced for minor offenses. They have served more than half of their sentence. They were elderly prisoners, prisoners with severe diseases, pregnant prisoners, or prisoners with children below the age of 2. The NPM could ask for specific statistics and release criteria to better be able to assess the measures taken. If more should be done, the NPM should recommend so. Moving to whether the authorities have established procedures for screening and testing on admittance and release. This is closely related to the initial medical assessment, which is mentioned in the Mandela Rules, Rule 30. I'll elaborate a bit on this because I think it's very important. According to Rule 30, all newly arrived prisoners or detainees should be examined by a medical doctor or another health professional as soon as possible in order to identifying healthcare needs and taking all necessary measures for treatment, in order to identifying any ill treatment that arriving prisoners may have been subjected to prior to admission, identifying any signs of psychological or other stress brought on by the fact of imprisonment, including the risk of suicide or self-harm, withdrawal systems resulting from the use of drugs, etc. In cases where prisoners are suspected of having contagious diseases, providing for the clinical isolation and adequate treatment of those prisoners during the infectious period, and determining the fitness of prisoners to work, to exercise, and to participate in other activities as appropriate. It is thus clear that the obligation to screening and testing on admission has a clear foundation in international standards. The actual implementation would rely on specific circumstances. For instance, which access does the Prison Health Service have to testing for COVID-19? In case there's no access to testing, the screening would have to be performed based on the presence of symptoms and possible exposure to persons with positive tests. But as for access to testing, the principle of equivalence of care would apply. Thus, access for detainees and prisoners to be tested for COVID-19 should be the same as in the general population. This is stated in Mandela Rules, Rule 24. It says, the provision of health care for prisoners is a state responsibility. Prisoners should enjoy the same standards of health care that are available in the community and should have access to necessary healthcare services free of charge without discrimination on the grounds of their legal status. Healthcare services should be organized in close relationship to the General Public Health Administration and in a way that ensures continuity of treatment and care, including for HIV, tuberculosis, and other infectious diseases, as well as for drug dependence, unquote. The release of prisoners which were mentioned above should also follow procedures for screening and testing so that the released person, in case of positive tests, positive symptoms, or exposure, may receive the appropriate treatment and accommodation after release. Again, deficiencies in the screening and testing procedure should give rise to recommendations from the NPM. Moving to which measures have the authorities taken to protect vulnerable groups. The vulnerable groups must in this context be defined by the public health authorities as those with an increased risk of serious or fatal cause based on their age and or poor health. Those groups should be considered for early release or parole to avoid a massive exposure to a potentially fatal disease. However, it may be argued that there's vulnerability beyond the course of a possible coronavirus infection. An editorial in The Lancet on the 4th of April addressed this issue and made the point that also groups who struggle with the crisis financially, mentally, and physically should be considered vulnerable. Some will rely on supplies from relatives, supplies that are now cut off due to cancellation of family visits. Others experience an exacerbated fear for the threat and the future consequences of the epidemic. Others again are, because of language or cognitive disorders, unable to understand the context and the messages sent by the authorities. Communication and information are probably the most important measures to mitigate mental reactions to quarantine and lockdown. So measures to be taken in support of vulnerable groups, in addition to the possible release, would be efforts to ensure information in a language they understand, access to hotlines, to news, and to meaningful activities. Excuse me. Moving to the facilities and procedures for quarantine. The information provided regarding facilities and procedures for quarantine should be clear and leave no room for arbitrary or even repressive use of quarantine. The grounds for quarantine are purely medical, and the prison health staff should be the final authority in such questions. Nevertheless, quarantine may imply isolation for 2 weeks, which is close to the upper limit for isolation according to the Mandela Rules, Rule 44, which says that for the purpose of these rules, solitary confinement shall refer to the confinement of prisoners for 22 hours or more a day without meaningful human contact. Prolonged solitary confinement shall refer to solitary confinement for a time period in excess of 15 consecutive days. Unquote. And according to Rule 43 in the Mandela Rules, prolonged solitary confinement should be prohibited. So just to stress that the standard quarantine period is actually touching upon the upper limit of what the Mandela Rule says about acceptable solitary confinement. This stresses the need to ensure meaningful contact and activities for those in quarantine in order to prevent severe mental health consequences on top of the fear for getting seriously ill. This regime should be scrutinized by the NPM. As stated in the SPT advice, safeguards should apply for the use of quarantine, and this should include the right to information about the reasons for the quarantine, the right to an independent medical evaluation, the right to legal assistance, and the right to inform third party. Essentially, the basic safeguards that we know from the system in general. The facilities should be described by the authorities, possibly supplemented with photos from selected places. In single-cell facilities, the place of quarantine will most likely be the prisoner's cell. But in prisons with bigger cells for many prisoners, they might define dedicated rooms for all of those in quarantine. This poses particular difficulties in administering the timing of the quarantine and should not be used. Procedures for family visits. These are obviously very important to prisoners as the way to maintain contact and a minimal level of normality. While the epidemic provides reasons for limiting at least the physical contact, the authorities should provide alternative ways of maintaining this important lifeline to the outside world. This might include extended possibilities for telephone contact and possibility of video contact. However, the possibility for relatives to legally provide food, clothes, and money to the prisoners should be maintained and follow procedures which respect both safety and security. The NPMs could go into detail and ask for statistics regarding the number and length of contacts between prisoners and relatives to be able to evaluate in detail how well alternative measures actually function. Moving to procedures to protect staff. The information provided by the authority under this topic should address all procedures of relevance to protect staff against COVID-19, be it from other staff, from inmates, or from relatives. This includes access to means of protection, face masks, visor protection smocks, as well as to disinfection, hand wash facilities, disinfectants, and information should be provided about any guidance and procedures that have been issued for the use of these means. Of particular interest are situations where the use of force and close contact with inmates is required, such as putting on handcuffs, interrupting fights, body searches, lead grip, and the like. Obviously, social distancing is not possible in such situations. It is highly desirable that the staff is well informed about what is expected of them in such situations, in particular vis-à-vis inmates known or suspected to have COVID-19. Another important area in relation to the protection of staff is guidelines for sickness absence, in particular for staying at home because of COVID-19-like symptoms. While many prisons suffer from shortage of staff and a high sickness absence rate due to stressful working conditions, it is important to prevent transmission that staff stay at home when they have symptoms or have been exposed to persons with positive tests. The risk of substantial shortage of staff at work due to COVID-19 should be mitigated, as I mentioned earlier, by organizing a pool of temporary staff on call. NPMs should evaluate whether efforts to ensure enough staff at work are sufficient. Has this anything to do with compliance with human rights? Well, obviously yes, because shortage of staff is very likely to involve limitations of human rights, more harsh security measures, more use of force, less conflict resolution, and less dynamic security. The prison health staff is also at risk of acquiring COVID-19 due to the proximity when examining inmates suspected or known to have COVID-19. Again, access to means of protection and procedures for their use is key. Access to such means and to tests should be similar to those for staff in the public healthcare system. Again, the NPM should evaluate whether measures here are sufficient or whether they should make recommendations. The last topic here is data on the development of the epidemic. This topic addresses the system's ability to collect and process data in order to monitor the development of the epidemic in the institution. In order to have an effective health information system, data should be collected and processed day by day with regard to suspected and confirmed cases among newly arrived prisoners, current prisoners, and released prisoners. Thus, each institution should at any time be able to give an account of the number and development of suspected and confirmed cases, the number of cases in quarantine, and the COVID-19 status of released cases. This will provide an effective feedback to the prison health service and management about whether measures taken are effective and sufficient or whether more measures are required. This information should be available at the institutional level as well as the national level. I probably do not need to remind that many states were actually rather slow in their efforts to contain the epidemic, and having an effective health information system is necessary in order to be aware how far the epidemic has developed and which measures are necessary. Time does not allow, but I would like to state that many, if not most, of the considerations above would also be applicable to other types of places of detention, notably immigration detention centers, psychiatric departments, and social institutions, for instance, for persons with development disorders. The second question that was addressed in the SPT advice and elaborated in this presentation is the conditions for undertaking generic preventive monitoring during times of restrictions of human contact. It is possible and useful to uphold certain monitoring activities during the pandemic, or should the NPMs put down their arms? Many NPMs, as I understand it, have actually put their activities on hold, considering that interaction between monitoring teams and prisoners would increase the risk of transmission to prisoners as well as to monitoring team members. The challenge, as clarified in the SPT advice, is whether NPMs could develop alternative ways of monitoring during the pandemic. There are several good reasons to move in that direction. Firstly, torture and ill treatment do not stop during the pandemic. Thus, the need for oversight mechanisms and preventive monitoring is as great as ever. 2. Measures to cope with the epidemic may limit the enjoyment of human rights, so maintenance of preventive monitoring may be even more needed than before the pandemic. And thirdly, maintaining awareness of the NPM may be important. A discontinuation of activities and awareness may make it difficult to re-establish the position and respect that applied to the NPM before the epidemic. So it's also a matter of visibility. Then, which are the possibilities to monitor without breaching the social distance requirements and respecting the do no harm principles? I will address written information received from the institutions and central authorities, interviews with recently released prisoners, interviews with inmates and staff through video or audio connection, and monitoring based on visits complying with social distance and use of means of protection. As mentioned before, an NPM could request very detailed information about the management of the pandemic in, for instance, prisons, as a basis for evaluating measures and providing recommendations. The same applies to generic preventive monitoring. In the Danish NPM, we have developed a practice of requesting very substantial information before the visit. On the one hand, this practice means that institutions are notified that we will undertake a visit at some point. On the other hand, in a system where many activities are put on record and reported to central authorities, there are limits to the beautification and cleanup that you are able to do in advance of the visits because things have been recorded. Again, this is obviously dependent on the context and the way the prison system is organized. But we have reached a balance where some visits are notified, some are unnotified, and some are partially notified. That is, we notify that within the next 3 months, we will visit the institution. This allows us to get the best of both worlds, namely substantial information in advance and low risk of beautification and cleanup. If the system is putting much data on record, it may be relevant to consider requesting reports about the use of force, including the supervisor review of the reports on the use of force. Disciplinary sanctions, primarily punishment cells, security cell, observation cell. The number of course of body searches and findings. The amount of threats and violence against staff and between inmates. the amount of suicides, attempted suicides, and cases of self-harm, policies and measures to prevent violence, and procedures for initial medical assessment, including the number of cases of suspected torture or ill treatment, and the reporting of these cases to the competent authorities. So this is like a list of potential data that could be requested from the authorities. It may be considered to ask for all reports from the last 3 years, to ask for all reports from the last year, or maybe the last 5 reports, depending on the expected overall number. An evaluation of this information may give rise to recommendations of changing the practice in the institution, for instance, regarding use of force or disciplinary sanctions, or at least to make an in-depth analysis of why the figures are as high as they are. Moving to interview with recently released prisoners, Dignity has developed a concept that we call indirect monitoring. This is an attempt to provide solutions to monitoring bodies which do not have access to physically enter the criminal justice institutions because the authorities do not allow so. This concept includes gathering of written information as described, as well as interviewing recently released prisoners and detainees about the conditions in the institution. While authorities may refuse to collaborate, it is in principle a possibility to request names and coordinates of the most recently 10 or 20 released prisoners and attempt to get an interview with them. Their contribution to building a picture of how detainees and prisoners are treated and how the detention conditions are may be highly valuable. Together with the written information, this may suffice to form the basis for recommendations. An advantage is that released prisoners are very unlikely to be subject to reprisals because they are in freedom. Using video or audio contact. Video contact is a potential way of achieving a direct contact with staff and inmates during times of restrictions of human contact. However, as any monitor of places of detention will be aware, the creation of rapport and confidence is key to a successful interview, and video-based interviews do not carry the same possibilities of establishing such good contacts. However, obviously, a telephone contact to prison management or staff could serve well as a way of elaborating information provided in writing. As for contacts with detainees and prisoners, this would also risk being an insecure means of communication and possibly put the inmate at risk of reprisals. However, establishing a telephone link, maybe a hotline, for prisoners to call the MPM in cases of torture, ill treatment, or conditions or treatment approaching this could be worthwhile considering. Again, here we should gather experiences in this area. And finally, monitoring based on visits complying with social distance and use of means of protection. The physical visits have, as I believe it, been abstained from by most NPMs. This is likely due to the mutual risk of transmission, that is the do no harm principle. Another reason, however, may be related to the use of protection equipment, face mask, etc., that may be required for maintenance of safety during a visit. In the early phases of the epidemic, social distancing may suffice as means of safety, but as the epidemic progresses and the knowledge of transmission by asymptomatic cases increase, and this approach may no longer be realistic. So undertaking interviews wearing face masks, etc., is neither likely to be effective due to the psychosocial barriers created by the protection equipment. So at least I would not recommend it. In conclusion, the COVID-19 epidemic provides new challenges to preventive monitoring bodies in terms of new areas to monitor and in terms of new obstacles for the monitoring methodology, the physical visits. NPMs should certainly enter into monitoring how authorities manage and prevent the spread of the epidemic. A number of international guidances provide standards for what to consider, but even the existing international standards, the Mandela rules, provide standards for screening on admission and equivalence of care, which are key standards also in a COVID-19 context. Generic preventive monitoring should not be halted, but may continue by means of alternative ways of achieving information from the places of deprivation of liberty, notably requesting written information and elaborating this information with phone contact to institution management, and possible interviews with recently released prisoners may be considered an indirect monitoring, which may prevent a total discontinuation of human rights oversight during the pandemic. Thank you for your attention.
Thank you, Jens, for that very enlightening presentation. Covered a lot of information, and I'm sure you want to catch your breath for a second. But I would like to give the opportunity for people to ask questions of the presentation and more generally. In regards to the questions, if anyone else wants to contribute, particularly Elena and June, if you'd like to make contributions as well, it'd be very much welcome. So I will start with, first question is from Marie Steinbrecher. Could you please just as well introduce yourself so we know who you are and what organization or your interest?
Hello, good morning. Yes, so I'm doing research on OPCAT and on independence. And so I'm looking specifically how NPMs can be independent and how they can interact with the government and maintain their independence. And my question is actually on that. So I've seen a lot of NPMs actually having their visits cancelled. So instead of them deciding they don't do their monitoring anymore, it's the state deciding for them that they have to suspend the monitoring. And often NPMs try to get into contact with authorities asking if they can keep up certain activities. And I think this is really important to be had. But I'm wondering what Jens thinks about the independence of NPMs. Does this restrict their independence in any way? Is there any good practice that we can do? Or what is your general opinion?
Stephen, do you want me to reply right away?
Yes, please, if you could.
Yes, sure. Marie, I think it's an excellent point, and I was not aware actually that some states had cancelled the visits on behalf of the NPMs, which is of course an impediment of their independence. I completely agree. It should be the sovereign decision of the NPMs how to exercise their mandate. Their mandate should not be undercut like this. So I would agree with you that a rather fearful reaction would be necessary on part of those in favor of an independent NPM. That's all I can say.
Does anyone else have a question? Ingrid?
Yeah, just wondering if we know how many countries globally have begun releasing prisoners as a direct response to COVID.
I can only say that I don't know, but as you're probably aware, APT has made an international hub that registers what the authorities measures, and I think that would be the most likely source of information of this kind. But it brings me to repeat my point from the presentation that I think it's very important that experiences are being gathered and processed, at least on behalf of the NPMs, of what are useful and successful innovations in monitoring methodology these days. It would be a shame if we don't collect best practices.
Elena?
Thank you very much, and thank you for allowing me to piggyback on this very interesting presentation. First of all, I wanted to give maybe just a couple of points of information about the monitoring situation in the UK currently. Some of the things that I have heard that, in addition to what Jens already mentioned, what I thought was very interesting, and this information is true as of 10 days ago. I've heard about the Northern Ireland Inspectorate and the Scottish Inspectorate doing their best to continue with actual on-site visits. But an interesting consideration that both of the inspectorates have is to how big a gap do they leave between their visits. So in one jurisdiction, they're visiting places, leaving 7 days between visiting one institution and then going to another institution. In another jurisdiction, they are having 2 weeks gap. So to make sure that they are themselves not transmitting and carrying potentially virus between the institutions. Particular emphasis on these visits is also the registers, and in particular the registering of anybody being placed in quarantine and how the institution is resolving the conflict, at least potential conflict, between the security and medical considerations. And I think this is something that is particularly important to see that whatever decisions are being made by the authorities, that they are properly recorded. And this is something that the NPMs certainly are very well placed to look at, even in those instances when NPMs are unable perhaps to carry out on-site visits. And if you permit me to speak just a little bit as a member of the Working Group on Arbitrary Detention, I think the working group has been very keen for a very long time to somewhat piggyback on the work of the NPMs, because of course whenever a national preventive mechanism, or for that sake any independent oversight mechanism, goes into any place of deprivation of liberty, when you are looking for or examining the conditions of detention, you're inadvertently also examining whether there are instances of arbitrary deprivation of liberty. And in the current context of pandemic, I think this is particularly a point that Jens was mentioning under your fifth point about the facilities and procedures for quarantine. This is something that is particularly potential for abuse and for arbitrary deprivation of liberty arises. These are decisions that need to be made by medical staff, but of course in places of detention the security considerations come into place. So if I may invite as much as possible for the NPMs in these difficult circumstances to examine and to pay attention to these procedures, that would be also very welcome by the working group as we elaborate on our views as to prevention of instances of arbitrary deprivation of liberty in the context of the pandemic. Thank you.
Thanks, Elena. Our next question comes from June Lopez.
June, I cannot hear you. I think you have to unmute your mic.
Yeah, I forgot. Sorry. Once again, thank you very much, Steve, for organizing this conversation. It's very useful, especially for us who are in the third world and really at a loss as to how to carry on with our mandate. I'm a member of the SPT, but also a member of our interim National Preventive Mechanism. And we are just waking up to the possibility that in spite of the complete lockdown in this country, we can still do something. Part of that inspiration came from the actions of the ICRC, which has established COVID facilities covering 3 regions in the country, and doing a lot of the work that really must be done with the government, but at the moment not being able to attend to the situations of places of detention because of the more major, bigger problem out in the free world, in this country, so to speak. My question is what my co-members in the INPM often ask: how do we deal with the huge stigma that is attached to being potentially exposed to COVID infection and coming from a place of detention. There is an argument that these prisoners are better off staying where they are and not threatening public health, as well as not being subjected to possible discrimination in the community. Is there any thought on this or any experience from dealing with the stigma, double stigma of coming from a place of detention and was potentially being exposed to COVID?
Unfortunately, I don't have a lot to contribute here. I agree with you that it's certainly a risk that there's a double stigma on prisoners, that both they're coming from the prison and they may be contagious in terms of COVID-19. I would like to remind us, though, that the view, which I think is common in the general population, that they are now behind bars and that is where they belong, this is simply not true. Actually, well, maybe not in the jails in Manila, but but in general, there's a lot of flow through the prisons. Actually, sometimes the flow is 3 times as large as the stock of prisoners per year. And that means that it's a very porous system, and there's a lot of interaction between former prisoners and the general population. And this is why we call prison health for public health, because there is not the bars to keep the prisoners away from the population. This is an
Sorry about that. Sorry, Jens, were you continuing?
No, I finished.
Okay,
Thanks.
Thanks. I have another question from Janice Adair.
Thank you, Stephen. Hopefully you can hear me and others. Thank you very much indeed. And just echoing the comment from others, thank you very much for the opportunity to join together and to share insights from across the world in this very challenging and unprecedented times. I'm the Chief Inspector of Corrections in New Zealand, so whilst I'm not a national preventative mechanism, I head up an inspectorate which is operationally independent from the Department of Corrections in New Zealand. One of the key things that I'd just like to share very briefly is in responding at pace to COVID-19 in New Zealand. New Zealand went to an alert level 4 status, which many of you will be aware of. I also, in terms of the inspectorate functions, really redoubled our efforts in terms of ensuring that we had best oversight and insights into the correctional environment, particularly in respect of complaints. So we doubled our resources in terms of our our management of complaints. We moved to a 7-day-a-week operation, and all of that critically turns to contact with and information provided to people in the Department of Corrections care. So we actually devised some posters which we sent to all of the prisons explaining the role of the inspectorate in these challenging and unprecedented times. And I've since written a letter, an open letter, to all people in the department's care, all prisoners and family and whānau. So I think really it's critically important that messages get out there in plain, simple English and in languages that also meet the needs of our prison population. But one of the key things, and I'm seeking some advice and information for what I know and understand very well, is the importance of civil society in terms of the National Preventative Mechanism framework. And I'm just interested in any thoughts that you and others may have in terms of how civil society could be engaged in order to give us best leverage in these challenging times.
This is a very good question. And of course, it depends very much on the nature of the civil society in different settings and how they interact with authorities and whether they have actually access to prisons or not. I would say that maybe the most basic role probably in third world countries would be to fill gaps of providing support and means and food to and health probably to prisoners where the authorities don't have possibilities to do so. I think that's a very commendable role. It's a humanitarian approach. It's not monitoring, but it's certainly something that is important. Another role I'd like to mention is an example from Sierra Leone, where Dignity is currently working with a very strong civil society organization called Prison Watch. And Prison Watch are monitoring all prisons in Sierra Leone on a very, very regular basis. And they have been asked to provide training to the staff, both the health staff and the uniformed staff in all of the prisons on how to manage COVID-19. I mean, some of the things we talked about in terms of screening and protection, basic understanding of this. And as we speak, we are in Dignity developing a curriculum together with Prison Watch that could maybe find use elsewhere too. And I think this role of a civil society organization of assisting with providing training curriculum and implementing training for prison guards and prison health staff on how to handle this is a very, very helpful and very important role.
Thank you very much indeed.
Did anyone else have a question they wanted to raise, even domestic questions as well? Sorry, just one second. Andrea?
Hi, can you hear me?
Yes.
Great. I just have a question around whether you see opportunities for advocates, whether that's, lawyers or academics, whoever's sort of involved, MPMs, whoever's involved in this sort of area, to work more closely with unions of police and prisons. I know there has been, certain instances where unions, for example, in the UK, are saying that they don't want to have that oversight from MPMs, given the added pressures they're under. But I feel like in this situation, the interests of the staff and the prisoners are incredibly closely aligned. And just wanted to get your views on whether there could be some strategic work done in this space.
I completely agree with you, and I think this touches on the relationship between monitoring and oversight bodies and those institutions and authorities being overseen, because in many places the authorities have a lot of reluctance to the concept of oversight and preventive monitoring, and feel maybe that the monitoring bodies are hostile and should be managed, and other authorities actually develop a very different role, a different understanding and view that monitoring is a very helpful endeavor in order to ensure and improve the quality of the service that they deliver. And of course, the latter attitude is more constructive and easier to work with for NPMs and others. And the NPMs do, as you say, have an interest in how the staff is doing, because the staff's well-being is key, as I also mentioned, to the service and security they deliver inside the prisons. And it's in both interests that the staff is not too much on their knees, which is currently the situation in Danish prisons. And we feel definitely an alliance with the unions, both the unions of the uniformed staff and the non-uniformed staff, that this is a matter of sufficient resources, and as I mentioned, a pool of temporary staff that can fill the gaps and not make the situation worse and worse as the epidemic progresses. So yes, I agree very much. There is a common interest and alliance with the staff unions and the staff interests, and we should be fully aware of that.
Thank you, Jens. I've had about 20 people join in the last couple of minutes, so my apologies for sending so many emails. So a lot of people might not have got the revised time, so they've missed the presentation and we're into the question and answer session. But there is still time to ask any burning questions you might have had before joining the session. We've got a host of experts with us here. So if anyone has a particular question, please indicate to me now, either through the chat box or raising your hand. Okay. Well, while we wait there, I might as well ask a question. Given the amount of sort of guidance coming out from various UN bodies, the World Health Organization, the CPT, European human rights, how can, I suppose, civil society best engage with monitors without jeopardizing monitors' independence to sort of push that messaging across to government agencies regarding release, regarding preventing solitary confinement where medical isolation is used, those sort of issues that you covered in the presentation?
I assume the civil society could exercise their ordinary function, namely to hold the executive accountable and to do advocacy, and maybe to join forces in terms of putting forward demands of resources and management plans. For instance, in many countries, the prison health service is separate from the public health service. I'm not aware of the situation in Australia, but this is certainly the case in Denmark and in many other countries. And this means that the prison authorities often do not have medical expertise to guide the development of procedures. And here we have to push the prison and probation services to actually work together with the public health care experts in terms of epidemiologists and infection medical experts, to make sure that the guidance that is developed in the prison and probation service for the institutions actually work. I think civil society could play a very important role in the advocacy and holding the authorities accountable to the international standards that have come out as different guidances.
Thank you, Jens. Alicia, would you like to ask your question?
Hi, everyone. I was just wondering if we could just have a clarification of the situation here in Australia as far as monitoring and access, because I know that there was a little bit of concern and different stories coming out about some people being able to access places of detention and others not. So that would be wonderful. And thank you very much again for this.
I think one of the monitors might be better to answer that in terms of what they know.
I can answer from the Commonwealth perspective if that helps. So yeah, I guess there was a bit of confusion and some incorrect media that was released in terms of saying, and I know that Steve jumped on it really quickly, which was great because it drew our attention to it. But the Department of Home Affairs had sort of said that a number of oversight bodies were actually not allowed to come into, and this is specific to immigration detention. However, we engaged with them very quickly to correct the record and make it very clear that we, although we've made a conscious decision given the current circumstances and given, I guess, the risk of harm to both our staff and to detainees to not go on site at this stage, that's very much a decision we've made, and it's definitely not something the department has imposed upon us, and we've made it very clear that that would not be the case at all. We definitely set the record straight, so they have updated their website to clarify that point, and as a result we've actually published and updated our website, our Commonwealth Ombudsman website, to kind of clarify that point and to also, I guess, more broadly let people know what's actually occurring in these current circumstances, and we're working, I guess, towards putting more kind of communication out about that so that people understand the circumstances. And just for a bit more context, the Commonwealth Ombudsman himself is reviewing that decision all the time. It's not an indefinite kind of thing. I know that we had sort of said until the end of April at this stage, and now that it's coming up to mid-April, he will again review that decision, but it's an ever-evolving kind of process. And we definitely have already sort of identified, because we have offices all around Australia, and obviously there are detention centres all around Australia as well. It's problematic with the fact that states and territories are restricted with travel. However, we've already identified people within certain offices who can visit within those states and territories and things like that, that if something arises through our remote monitoring methods at the moment, we could visit if we needed to. So yeah, definitely trying to set the record straight on that one and change, I guess, the narrative around that. Thanks.
Thanks very much, Min. Did any of the prison inspectorate staff want to comment on whether they've had any, I suppose, bans imposed upon them?
Hi, Stephen. It's Emily Collett from the Inspector of Custodial Services in New South Wales. So yeah, we're able to continue to visit if we choose. We've chosen not to for the time being, but similar to the Commonwealth Ombudsman, that's a continually evolving, I guess, decision depending on what's going on. So yeah, as far as routine visits are concerned, we're not undertaking those at the moment, but yeah, we're still able to go in whenever we think it's necessary.
Great, thank you.
Hey, Stephen, this is Jennifer Aegis from the New South Wales Ombudsman. I got a late invitation to join in today. Probably could just let people know, obviously, at the moment, we're not visiting into either correctional or juvenile justice centres for the same reason as the inspector just mentioned. But we are certainly not barred, and it was specifically written into the public health legislation that came out just recently that we were still able to go in if and when we felt necessary. We do have a line that the inmates and young people in custody can call us on, and they are continuing to do that. And we are receiving roughly probably 20 calls a day from people in custody across a range of issues, not all obviously relating to COVID, but clearly a lot of health concerns and questions, and just general issues about how what's happening with them and that. And to assist with that, we're having three times a week teleconferences with head office at Corrective Services, and regular contact with the Executive Director of Youth Justice as well. So special posters were put up for all of the inmates and young people to know that this is a special phone line. It does have limited operation hours. It's only running 9 till 12 and then 1 till 3 every day. But we're still getting as many contacts as we would during a normal day of operation, normal daily operation, and still making contact with the centres about the issues that the people are raising with us. So kind of business as usual, but squeezed into a remote working environment.
Okay, thanks, Jennifer. I have a question from the Commonwealth Ombudsman to the New South Wales Ombudsman.
Hello, yes.
Hi, it's Min Lovell from the Commonwealth Ombudsman. I with regards obviously to your complaints and the fact that you're not doing on-site inspections at this stage, have you had an increase in complaints or contacts with regards to the quarantine within your state, as in those people who have returned from overseas and are having to undergo the 14 days of quarantine?
So that's a bit of a tricky sort of jurisdictional issue for us. We have been in touch with both Health and DPC, Department of Premier and Cabinet, because the quarantine is a combined effort between the New South Wales Police Force and the health people. Our jurisdiction in terms of the agencies extends only as far as health and or Department of Communities and Justice, not to the police force, because there's a separate organisation in New South Wales, the Law Enforcement Conduct Commission. So our the availability of us as a complaint agency was included onto the newsletters and information sheets that went out to people who are in quarantine. Not initially, but we were able to get that included. And we did actually receive a couple of inquiries through our online complaint system from people who were in quarantine, and we responded to those as well. Great. So obviously, as different to people who are normally detained by a public authority, which definitely comes under our jurisdiction, these people have free access to the internet and are able to call us easily at any time, and also to access information that we have on our website, which can assist them as well.
Right. Yeah, it's great that you I guess that you managed to get that information included on the newsletters. That was it, because I guess we had the same kind of issues with regards to jurisdiction and understanding of that clear delineation of, I guess, responsibility, or the issues with that delineation of responsibility.
Exactly.
So great, thank you so much for
that's okay,
letting me know.
No worries, thank you.
Great. Did any other jurisdictions want to comment on what they're doing?
So I mentioned, hi everyone, sorry I'm late. Can you hear me?
Yes, Claire.
No. Yeah, okay. Is it right time to step in, or? Yeah,
if you want,
Okay. Just that in immigration detention as part of academics for refugees, we've drafted an open letter which has got about 1,000 signatures, and we're planning to, we've got a media release that we're sending out tomorrow to hope to get more coverage of that, to push for change. And we're also focusing on not just the federal government but the state governments in relation to immigration detention, emphasising that this is a public health issue, so it falls within state jurisdiction as well. And we've got some positive responses from South Australia and Victoria that they accept that it's a public health issue, so that's really positive. Thanks.
Thank you. Okay. I think it's probably interesting to note that in New Zealand, the situation for the New Zealand Ombudsman, which has the OPCAT role, has been designated as an essential service during the level 4 restrictions. So obviously governments deal with this differently and place different priority on oversight. But I think I was personally wanting to know if there were any restrictions in place in Australia, given what New Zealand has chosen to do. it doesn't seem like that's the case. That's great. Did anyone else have a question? Janice, did you want to ask another question?
Thanks, Steve. It wasn't a question necessarily, but just to turn to the point that you raised in terms of restrictions being placed on entry to sites. When New Zealand went to a level 4, which is essentially complete lockdown except for essential services, which is, gosh, just approaching 3 weeks ago, I think. Immediately on day one, I was in discussions with the Chief Executive of Corrections to talk about a plan for safe re-entry. So we prepared a paper to the Chief Executive which set out the principles well espoused in the human rights language that we all know and trust in terms of the monitoring by NPMs and other NGOs. That plan in principle was approved, but the inspectorate should work at pace for a planned re-entry, and that re-entry will be based on a individualised plan for each site, and that preparation is well underway, and we hope to execute that planned re-entry from next week, and the presentation of short form reports in a relatively timely and efficient way back to the Chief Executive. So not sort of drowning in the detail of lengthy and sometimes unfortunately turgid inspection reports which take a while to get through the system, but actually just been proving ourselves to be agile and responsive in this environment. So I think, notwithstanding, you're absolutely correct in your reference to the Ombudsman, that they've been considered an essential service, as so too has the Office of the Inspectorate. So limitation only until there is a safe re-entry plan, which is well underway from our perspective.
Great. Thank you very much for that clarification.
Stephen?
Oh yeah, go ahead.
It's Deborah Colburn here. I'm the Chief Mental Health Advocate in Western Australia, and we have a rights protection role for people in psychiatric wards and psychiatric hostels over here under the Mental Health Act. So it's functions and powers that we have. Just to let you know, we are still going in, but we are also trying to do more work by phone and all that sort of thing. But in terms of hospitals, one of the issues we've got here is that we have 5 different health service providers, and they're all doing things differently. And what's happening is at ground level, and for the right reasons, because there's obviously been a lot of anxiety around COVID, but we've had, for example, some wards completely locked down, no visitors in, no ground access, those sorts of things, and yet there's no public health directive here to that effect for any of our wards actually, and we get hit with issues. We get told, oh, Public Health Act out trumps, to use that word, or is it overrides the Mental Health Act, which is actually not true in terms of our law here anyway. So we've had some interesting times educating people in particular who are trying to do the right things, but who, to my mind, are doing things which are not proportional. And our Public Health Act here requires it to be proportional, by the way, but also they're doing things, as I say, they think for the right reasons, but it is severely restricting, detaining people. And on some of these wards, we're talking about patients who are voluntary, as well as involuntary patients who actually under our Mental Health Act here have a right to visitors, which has not been overrun. So I wondered if anybody else online is involved in the psychiatric wards at all. Thanks.
Would anyone like to respond to that?
I mean, I'm not involved in the psychiatric ward side of the house, but have you touched base with the WA NPM at all with regards to the potential of gaining access through that mechanism?
Basically, I don't need to is the answer to that, because I have powers and functions. So the problem, though, is really just the way things are flowing here.
Yeah.
Rather than anything else. So yes, I can deal with them, but I just wondered if other states were seeing the same sort of thing.
Yeah.
No, I think I can sort of answer unofficially from the New South Wales official visitors' point of view. So we've had not that I'm aware of, any problems continuing monitoring program, but that's been from a remote monitoring aspect. So we're no longer going in to hospitals. But as far as I'm aware, there's been no pushback, and most local health districts have been quite accommodating for us, and understanding that we need to continue this important role.
Sorry, I should make clear, when I say the visitors, I'm not talking about things like New South Wales visitors. I'm talking about family members and others. We've got no problems going in. They're not stopping us going in. Our powers are quite clear. I was actually talking about, so if you lock down a fairly large ward with a fairly long-term patients, and they're not allowed to see family, there's one phone or two phones maybe on the ward to call family, so nobody's allowed to visit them. They're not allowed out at any stage. To me, that is not proportional, especially to the risks over here in Perth. So we land, and as I say, they're actually doing it in breach of the Mental Health Act, as it turns out, too, unknowingly, and for all the right reasons. But so, I mean, do you know of any wards there that have totally locked down, won't give ground access, won't allow visitors, won't allow family to visit?
Not myself, sorry, I'm not aware, but I'm sure I can get an answer to that from the New South Wales perspective. Jens, did you have any comments on that, particularly from a human rights perspective?
No, I'm afraid I don't have any contributions here. Stephen, your mic is muted.
Oh, I was saying, if anyone wants to make any further questions, noting that it's very rare to have 3 UN representatives in the one chat. So Elena has a question.
It's actually not a question, it's just a little reflection. Relatively recently, there was a legal challenge under the Mental Health Act in England about precisely the point that the colleague just raised. This concerned a young man, actually a child still, who has been in mental hospital for very prolonged periods of time, and under the provisions of COVID virus, his contacts with family were severely restricted. And that went to the court case. And I just literally just sent you a link, Stephen, which colleagues may want to pursue further to see how the issue was dealt with in England. In short sum, the NHS, the National Health Service, had to change its guidance and to ensure that other means of communication for this disabled young man were provided so that he's actually able to be in touch with his family. Thank you.
Thank you.
It's similar to what our learned speaker sort of mentioned earlier about doing some analysis on statistics about the visitors the number of visits that used to occur prior to these restrictions, and then making sure that whatever measures that the centre put in place were proportionate, I guess, to what was previously offered. So if they used to have access to friends and family through face-to-face visits, and obviously given the circumstances they can't anymore, you'd like to think that they could at least facilitate video links and things like that to try to maintain that contact. And at least, yeah, it was something that I had noted as something that I would like my team to look into with regards to making sure that there are proportionate kind of measures put in place to allow those visits and that contact with friends and family to continue to occur.
Thank you, Min. I think we'll have time for one more question if anyone would like to ask a question. Alicia and Margaret. Okay, we'll make it two. Alicia and Margaret.
Hi, sorry, I've had two. That's not very fair, is it? I just wanted to ask, so given that increased security environments make the prevention of torture really difficult, so it gives rise to the conditions that usually contribute to an environment where torture is more prevalent. What is it that you think we should be doing in our respective jurisdictions to ensure that we don't see a rise in conditions and treatment that amount to torture?
That was a very broad question, and that was what my presentation aimed to address. I think it is important that NPMs and other oversight bodies think out of the box now and find ways to, maybe the most important thing is to show that they're still present, because I think it would be very risky to, as I also said, to put down the arms and to reduce the visibility. We believe, I guess, that one of the mechanisms is the deterrence, that actually there come people from the outside into the institutions and look at what goes on. And if we don't, we will allow things to deteriorate. So be it personal, be it in writing, be it on phones, be it with hotlines, I think that's up to the single NPMs which ways of operating are most appealing. But I think the bottom line is we need to do something, and we need to continue to do something in order to show our continued presence.
Thank you. And Margaret, the final question.
I'm just going back one step to talking about particularly patients, but also detainees who no longer have access to visits. It would be interesting to hear about the actual provisions that are being made for Zoom meetings and use of other technology so that they can retain contact with families. And then I was also thinking about the situation where you've got the family members in the real but lockdown world, possibly from Indigenous communities or from refugee communities who have very limited access to the kind of technology that they have limited access to the technology that would allow them to maintain this contact, and whether that any thought has been given to how you can manage that. Thank you.
Thank you very much. I think everybody acknowledges the need to maintain contact between relatives and prisoners and detainees, even in spite of the lack of physical contact. And many authorities have actually been offering iPad video contacts. And I don't think we know a lot yet about how this works. Is it how insufficient or sufficient is this way of upholding it? But certainly the important goal, I think, is to maintain the families, to maintain that when the prisoner gets out, there's still a family waiting for him or her. And maybe even we have women as a more vulnerable population here, because to be frank, many females in the family are very faithful and responsible in maintaining the family functioning until the husband gets out. But I'm not so convinced that the same applies the other way around, that the male relative is maintaining the family functioning until the female prisoner gets out. And of course, this is a factor facilitating leading a law-abiding life and being rehabilitated, that the family is in fact there. So I think everybody acknowledges that this contact is so important also for future crime and preventing future crime, that it must be upheld. But you touched also about another type of vulnerability, namely the general vulnerability of people in the population that risks being mentally damaged by the lockdown and isolation because of particularly poor possibilities of communicating with others. Maybe they don't have a mobile phone or an iPad. They are unable to maybe move down the floor to get out and meet other people. And they are very vulnerable. Some public health people think we are facing a depression epidemic as a consequence of the lockdown. And here as well, we have very vulnerable people. I'm thinking also about traumatized refugees that don't speak the language and don't understand the messages. So in general, vulnerability goes far beyond, as I mentioned, the vulnerability of being elderly and having health problems.
Thank you, Jens. I think we'll leave it at that. Again, I apologize to those who had the mix-up of times and missed the actual presentation, but I have recorded the presentation, which I'm sure if Jens is happy for me to share, I can share that with those who have been invited. I would like to, of course, thank Dr. Jens Modvig on behalf of the Australia OPCAT Network for agreeing to the presentation and so soon after Easter. So I thank you for that. And it's been very edifying, very informative for me, and I'm sure for everyone else. We've gained a lot from it. And as you said at the beginning, this is a very new world for all of us as monitors, but also civil society and those with an interest in human rights. So it's really a developing space, but having these opportunities to converse as a global group really needed at this time. So thank you to everyone who's been able to join from abroad and in Australia. And I hope you found it as useful as I have. And again, I think we all extend our appreciation to Jens for your time.
Thank you very much for the opportunity.
No worries. Thank you very much for joining, everyone.
Thank you.
Thank you.
Thank you.
Yeah.
Thanks.
Thank you, everybody. Thank you, Jens.
Thank you,
Stephen, for
Stay
organising.
well, everyone.
Hope to do this again.
Yes, I think we will.
Thanks, Steve.
No problem. See you all.